Renal osteodystrophy. So, in case of the kidney being dysfunctional, what will happen to the level of active vitamin D? Up or down? Down. So if the level will be down, you can think what will happen to the calcium level. Yes, exactly, it will be down because we know that calcium get reabsorbed with the help of what? With the help of vitamin D from the intestine and also from the kidney. Exactly, it's the 125 form. So the patient with renal osteodystrophy, he will have hypocalcemia and hyperphosphatemia. You're like, the hypocalcemia I get, but why hyperphosphatemia? Well, do you remember a hormone called PTH? So this PTH is doing what? The PTH function is to reabsorb calcium and excrete phosphorus. So let's think about it. If we say that, and it excrete the phosphorus at which tubule? Secrete the phosphorus at which tubule? BCT. What about calcium? Where it's getting reabsorbed? Which tubule? Okay, DCT. So if this patient has kidney dysfunction, all of his tubules are messed up. They cannot work. So you cannot secrete the phosphorus out. So you will have hyperphosphatemia. Yeah? You cannot reabsorb the calcium. So you will get what? You got it? Hypocalcemia. And failure of vitamin D hydroxylation is associated with chronic kidney disease because vitamin D, 125 vitamin D is made inside of the kidney. So that will eventually lead, this hypocalcemia will activate a hormone. It will activate the parathyroid hormone. And when your parathyroid hormone will be activated, you will have a secondary hyperparathyroidism. What does that mean? Secondary hyperparathyroidism, it means that your parathyroid hormone has increased only because your calcium level was low. And when you have secondary hyperparathyroidism, if it's for just like short period of time, it's okay. But if it persists for years and years and years and years, your parathyroid gland becomes irresponsive. It becomes irresponsive. She was like, okay, I don't care if the calcium was low. That's why she's high in this case. She's like, I don't care about that anymore. I will keep secreting without anybody controlling me. So we call that tertiary hyperparathyroidism. If secondary poorly managed, so if secondary hyperparathyroidism was not managed correctly, you will develop tertiary hyperparathyroidism. Again, the difference between secondary and tertiary. Secondary, you have high parathyroid hormone. Why? Because you had what? Low calcium. That's why you have high parathyroid hormone. Secondary to the low calcium. In case of tertiary, you have high parathyroid hormone. Why? Well, basically the parathyroid hormone got enough from this low calcium. So she was like, I'm going to secrete parathyroid hormone regardless of the fact if the calcium will be high or low. I don't really care. The parathyroid hormone will be always high. I like to think about it like cancer actually. Like it's high regardless of the fact how much calcium you have. High serum phosphate can bind to the calcium. So the phosphate can chelate the calcium. That leads to tissue deposition. And that can lead to less serum calcium. I have a question, guys. If you have phosphate deposition inside of the tissue with having really high phosphate level and having normal tissue, which form of calcification is it? Is it metastatic or dystrophic? It is metastatic, guys. Metastatic. Why? Because the serum phosphate is high. Remember, metastatic calcification happens on normal tissue. While if we speak about dystrophic calcification, it's happened at pathological tissue. In this disease, the tissue deposition are happening all over the body in normal tissue. So it's metastatic calcification. Okay, so the patient will have low 125 hydroxyvitamin D3 and also will have low basically absorption of the calcium from the intestine. Why? Because of the low vitamin D. And that can lead to, this is important, subperiosteal thinning of the bone. Let me show you a picture of renal osteodystrophy and show you what is this periosteum and all of this stuff. Just a second. So this renal osteodystrophy, it goes something like this. They like to show an x-ray of it and be like, what's up? So you can see here, I hate these ones. Oh yeah, this one they show most often. Okay, so the uppermost portion, we call it the periosteum. You can see under it, the bone looks blackish. The bone should not look blackish. The bone should look white, really, really white. If it has black inside of it, that means that the bone is really thin, okay? So x-ray of the femur. Okay, so you take a look. This is a normal leg, it's white. He has a fracture here, but doesn't matter, it's white. But if you look at this patient, it's black in the middle. So that's osteodystrophy, okay? Also, you can see like, poorly development of this area, plus they look blackish from the inside, yeah? Blackish from the inside, that means less mineralization of that bone. This is a perfect picture. See? Areas of emptiness even. Okay, let me send this. Okay, so the next thing we are going to speak about is this. Renal cyst disorders. There is many diseases that can lead to formation of cyst in your kidney. You have something called autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney disease, autosomal dominant tubular interstitial kidney disease, and finally simple or complex renal cyst. Okay, so starting with the renal cyst disorder. If we want to compare between autosomal dominant and autosomal recessive disease, can someone write me what is the difference between autosomal dominant and autosomal recessive disease? What makes the difference? Let's start with the pedigree. The pedigree of autosomal. So if we speak about the pedigree to start with, it will affect every generation. You are totally correct regarding the, actually I was going to speak about that later. Yes, so if we speak about the pedigree, autosomal dominant pedigree. Notice, it's affecting every single generation. That makes it dominant, okay? So if you take a look at this, first generation affected, second generation affected, third generation affected, fourth affected, fifth affected. Every single generation is affected. That makes it autosomal dominant. You can see that it affects both male and female. Remember, females are the circles, male are the squares. And it's affecting both males and females. That makes it autosomal, not X-linked. So there's actually 2 videos I want you guys to watch after we finish our session, okay? Basically, there is a few diseases, not 1, not 2, there is like 12 of them that are autosomal dominant, and there is a few diseases that are autosomal recessive. How I keep them straight? I have to say, there are so many diseases, it's basically almost impossible to remember all of them. So there is this song. Von, ALS, RBM, EN, Tubes and Spheres and Huntington, Marvin, Ehlers-Dan. Well, anyway, you can see that there is this song that you can correlate with it, all of the autosomal dominant disease. All of the autosomal dominant disease that you need to know for the USMLE Step 1 in one song. Perfect. Okay, let me send you this. Okay, and there is one more, but this one is for the X-linked So there is one more for the basically X-linked diseases. Okay, let me not waste time on this. I will send it to you after the class. Basically, like you just have to memorize this song, and you will just say it in the back of your head, and it becomes a second nature to you. So here we have renal cyst disorder, autosomal dominant polycystic kidney disease. So the patient will have numerous cysts in the cortex and the medulla. You must know all of the autosomal dominant disease have late manifestation. As you said, guys, it's more in adults. So this numerous cyst in the cortex and the medulla will be in who? In adults, not in a young person. Okay, they will cause bilateral, that both of the sides will be affected, enlarged kidneys, which ultimately destroy the kidney parenchyma. Look at this freaking things. It's destroying the kidney basically. And in this disorder, it presents with combination with flank pain, hematuria, hypertension. Why do you think hypertension, guys? Why patient like this with kidney failure will have hypertension? It's activation of the RAS system. Okay? Plus, they have more sodium inside of their body, which lead to hypervolemia, 2 in 1. Also, they can have urinary infection. So the common question would be, why the hell they would have urinary infection? Well, here's the thing. This is your kidney. And the cysts are all over the place. Yes? They will lead to reduced clearance of the urine here. So they will create a stasis. The stasis, when it occurs, who likes stasis? You guessed it, bacteria. Bacteria like stasis. So when the stasis occurs, the patient will have what? Basically, the patient will be suffering from that problem. It will have urinary tract infections. Okay, so the next one, it goes like this. Okay, it presents with combination of flank pain, hematuria, hypertension, urinary tract infection, and the progressive renal failure in 50% of adults. Sadly, the only way you can help these patients is with renal transplant, because otherwise there is nothing else you can do for them. You can give them antihypertensive drugs, you know, but still, autosomal dominant polycystic kidney disease. I just want to show you that CT they keep showing for everybody. Okay, so first of all, look how ridiculous size this thing is. It's a humongous. So let me send this. It's really big. So on an ultrasound, you can see all of these cyst cavities, which represent polycystic kidney disease as well. Also, this is the picture I was looking for. Well, no, not this one. CT. Yes, this one. They love to show you this picture. Where are you guys? Here you are. And this one, and why this one especially? This one, they love it the most because they will show you this, and when you see multiple masses inside of the liver, you'll be like, oh, this is cancer. But no, it's not cancer. I hope somebody will write a note about this one actually. It's not cancer. You have multiple cysts in the kidneys, and there is cysts inside of the liver. This is polycystic kidney disease. It is not cancer. It's not metastatic cancer. So, well, here the patient will have a mutation in the BKD type 1, polycystic kidney disease type 1. 85% of the cases are due to chromosome 16 affection, while polycystic kidney disease type 2, which is 15% of the cases, are due to chromosome type 4. I will tell you guys how I remember it. It's 4 multiplied by 4, it's 16. So you just need to memorize one of these. It's either 4 multiplied by 4 is 16, so that's BKD2, BKD1. Okay, complications include chronic kidney disease and hypertension caused by the increased renin production. which is due to the activation of the RAS system. Your whole RAS system will be activated. Well, you know, these patients will have cyst in the kidney, but they have cyst everywhere in other places. They have cyst in the kidney, cyst in the liver, and cyst in the brain. The cyst in the kidney is the polycystic kidney disease. We know that. Well, what about the cyst in the liver? Benign hepatic cyst. It's written here. Benign hepatic cyst they can develop. You are like, okay, where it is? It's here. See this? This is benign hepatic cyst. Okay, what else they can have? Perianeurysm. So perianeurysm is a form of aneurysm that can be inside of your brain. We will discuss it much more deeply when we speak about the CNS. And this perianeurysm mostly like to affect the communication of two arteries. Okay, so basically this is the perianeurysm, and you can think about it. Can this rupture? The answer is absolutely yes, it can rupture. So if it rupture, it will lead to some type of hemorrhage. So which type of hemorrhage it will lead to? You must know and master the idea that it will lead to subarachnoid hemorrhage. Okay, so the form of hemorrhage that it will lead to is subarachnoid hemorrhage. So the subarachnoid hemorrhage is highly specific, that when you take a look at the brain, there is this area which we call cisterine of the brain. Cisterine of the brain, which is basically the tight junction between the brain lobes. They will be full with the blood. And when you go to this patient and do a lumbar puncture on him, you will see something called xanthochromia. Xanthochromia. Xantho means yellow, and chromia means color. Remember, Google Chrome. Chrome means color. So in the CSF analysis, you will take a look of this patient and you will see xanthochromia. Why it's yellow, not red? Why do you think, guys, it's yellow, not red? Because it's a little bit old. It's yellow because the hemoglobin was converted, was converted to bilirubin. Okay? Excellent. Okay. So, let's do the next thing. Okay, so they have perianeurysm that can rupture, leading to subarachnoid hemorrhage. We are done with that. They also can have mitral valve prolapse. Guys, tell me please, mitral valve prolapse, will the sound increase or decrease if I increase the afterload? Let me repeat the question. If I increase the afterload on the heart, what will happen to the amount of the blood inside of your left ventricle? The amount of the blood of the left ventricle, if you increase the afterload, will increase because it's hard for the blood to exit from your left ventricle. Remember, this is your left atrium, left ventricle, your aorta. If your afterload is high, it's hard to exit. So more blood in the left ventricle. If there is more blood in the left ventricle, the chorda tendineae will be stretched. No, it's not the opening snap, it's the click. Opening snap is for mitral regurg. Remember, I told you, a click my variable point, okay? But the snap or for mitral stenosis, that's different. Sorry, I just said something wrong. Mitral stenosis have the opening snap. MVB, which is mitral valve prolapse, have the mid-systolic click. Okay, click my variable point. Okay, so if we speak about diastolic and which one is systolic, which one is diastolic, this one is diastole, while this one is systole. Okay, it's two different pathologies. So if we speak about increasing the amount of blood inside of your left ventricle, that will lead to stretching of the chorda tendineae, which will reduce the sound of the murmur. It will prevent it from parachuting into the left atrium when you increase the amount of the blood. Okay, so benign hepatic cyst will occur as well. Also, this is new, but it's also diverticulosis will occur as well. Basically, many cysts all over the place. How do you treat it? You need a kidney transplant. You can give antihypertensive drugs just to prolong their life, because not to die from the hypertension, basically. If hypertension or a proteinuria develop, you can treat with an ACE inhibitor or ARBs inhibitor. Please know, guys, ACE and ARB inhibitor are always considered to be renoprotective. Renoprotective drug are ACE inhibitor and ARBs inhibitor. Again, if I have a patient who's 6 years old, comes to you, you check his kidney, you see, yes, there is a few drugs that we consider them to be renoprotective, which means they protect the kidney from damage, okay? These drugs include ACE inhibitor and ARBs inhibitor. Why? So they decrease the two things. First of all, they decrease the remodeling of the kidney. The second thing, how they do that? By dilating your efferent arteriole. When they dilate your efferent arteriole, they decrease the GFR. Decrease in the GFR reduce the amount of filtration fraction. Reduction of the filtration fraction reduces the stress of the glomerulus. Reduction of the stress from the glomerulus lead to less remodeling. So it goes something like this. ACE and ARBs lead to what? Dilatation of efferent arteriole. Okay, that lead to what? Less GFR and less filtration fraction, which lead to less hydrostatic pressure of the glomerular capillary, which lead to less sclerosis and connective tissue formation, which lead to less remodeling and less kidney dysfunction. So, okay, let's go back here. If you have a patient, he's 6 or 7 years old, he has a polycystic kidney disease. Is it autosomal recessive or dominant? He's 6 years old. Okay, it's recessive, it's correct. If you have a baby, or you know what, I'm going to make it worse. Autosomal polycystic kidney disease. Can you see it in a patient in his mother womb? I mean, he's still in the uterus. Can you see polycystic kidney disease in a baby in the mother uterus? The answer is yes. You are like, what the? Well, yes, you can see that. And that can lead to Botter sequence. Why it can lead to Botter sequence? Because of oligohydramnios. Exactly. No functioning kidney. And it will be autosomal recessive polycystic kidney disease. Let me send this picture actually. You can see the child has Botter sequence, and you can see that in his kidney there is these empty spaces. This is his polycystic kidney disease. Okay? So one more, this is polycystic kidney disease in this baby. Okay, so yep, this is an ultrasound and you can see many cysts here. So it can happen even after birth, and the baby will have the dysfunctional kidney. Dysfunctional kidney will lead to less amount of urine making. If you make less urine, you will have oligohydramnios. If you have oligohydramnios, you are going to develop Botter sequence. If you have Botter sequence, you are going to develop what? Well, pulmonary hypoplasia. you are going to develop pulmonary hypoplasia. There is high chance this baby will die. Okay, good. This is the cyst under histology. You can see them, empty spaces. I know this topic has a lot of pictures. Okay, so let's go back. Okay, so for autosomal recessive polycystic kidney disease, cystic dilatation, this is important. If you had to remember something, you must know that it's the collecting duct, okay? So it's the collecting duct. Now comes my question. The collecting duct comes from which embryological origin? Which structure give you your collecting duct? Was it the metanephric mesenchyme or was it the ureteric bud? It was the bud, exactly, ureteric bud. What about your distal convoluted tubule? Mesenchyme or mesenephric blastema, they also call it. Be careful, it has two names. Mesenephric blastema or metanephric mesenchyme. Okay, so the next one, they write, often presents in infancy associated with congenital hepatic fibrosis. You are like, yeah, hepatic cyst. No. It's hepatic fibrosis, not hepatic cyst. It's different. Why? Because there is one thing you must know about. It's called fibrinocysteine. Fibrinocysteine. This thing called fibrinocysteine is basically one protein that will be overmade inside of your kidney, and that will lead, because of the genetic mutation, this fibrinocysteine, and that will lead to fibrosis of many organs. So fibrinocysteine. So it's written like this, fibrinocysteine. So that will be present in case of polycystic kidney disease, which can lead to liver fibrosis, fibrinocysteine. So you must know that in these diseases, there is something called fibrinocysteine, one other thing called polycysteine. These are names of genes, basically, okay? Polycysteine as well, okay? And one third thing is called polydactyl. Well, that's everything they can ask you about. There is nothing else they can ask you about except of these three. These are present in cases of polycystic kidney disease, okay? The mutation are in these, basically. Okay, so let's take a look here. It's associated with congenital hepatic fibrosis because of the fibrinocysteine, and significant oligouric renal failure in utero can lead to Potter sequence. We discussed that. Concerns beyond neonatal period include systemic hypertension. Why? Can someone tell me why these patients have hypertension? RAS activation, excellent, because increased renin. So, they can have also what? They can have progressive renal insufficiency, obviously, and portal hypertension. Why the portal hypertension? Because of the hepatic fibrosis. Why the hepatic fibrosis occurred, guys? Why do these patients have hepatic fibrosis? I will tell you in a second. Yeah, the mutation of the fibrinocysteine. Okay, for the patient, for the student who asked about why RAS system is activated in this disease. Look, this is a kidney, yes? And if we go histologically into this kidney, we have here your nephron, goes like this, goes like this. I like cardiology. It was easier to draw the structure of the heart. Okay, so the cysts are originating from which area? Was it the DCT, collecting tubule, or proximal tubule? Collecting tubule. Yes, it was the collecting tubule. So the cysts are being made here. Okay, well, make them. I'm not scared. Okay, we make more cyst here, more cyst here, more cyst here. How many nephrons do you have in your kidney? 1 million, around 1 million. Per one kidney, you have around 1 million. Okay, so this cyst has been formed. Don't you think they can compress vessels nearby? The answer is yes, absolutely correct. They can constrict vessels nearby. Well, which vessel, for example? They can compress any single vessel that is near them. For example, it can be afferent arteriole, efferent arteriole, doesn't matter. Any vessel that going near them. But there is a chance that here and there they can constrict one of these. Yeah? The afferent arterioles. If they do that, the baroreceptors will be like, okay, let me start that RAS system. Because remember, when baroreceptors are activated, they release, they go and activate the juxtaglomerular cells to secrete renin. Yes, and renin lead to activation of the RAS system. Yeah. So basically, what you need to know that if the patient has a polycystic kidney disease, he will have oversecretion of renin because of the activation of the baroreceptors, which will lead basically to hypertension. Okay, so here it goes something like this. So we spoke about dominant, we spoke about recessive. The main thing was the age, yes? And now autosomal dominant tubular interstitial kidney disease. This is a low yield pathology, but it's nice to keep it in the back of your brain, you know? So it's also called medullary cystic kidney disease. Medullary cystic kidney disease. It causes tubular interstitial fibrosis. So the main idea here is more than speaking about actual cyst, it's about fibrosis. So what does that mean? So normally in polycystic kidney disease, the kidney size, was it big or small? In polycystic kidney disease. Huge. I mean, just take a look at that. If you take a look at this, look at this freak. Doctor is standing in front of them and they are bigger than him. But if we speak about this disease, autosomal dominant tubular interstitial kidney disease, well, in this disease, they will be really, really small. Okay? So the idea is like this. The cysts that form are not as big as this. The cysts are micro. They are super, super small. And they are so small that you cannot see them in your eye. You need a microscope. But they can lead to fibrosis of the kidney. So what are you going to see on that pathology? Small kidneys. That's the problem. The kidney is fibrotic and small. That's it. It's really rare. That makes it really difficult even to see. Okay, this is it. To see it. So if you... Okay, actually, it's rare that you can find a picture like this. So it's nice that we found one. Okay, so what I want you to know. Notice, there is little cyst inside of the kidney. Yes? Okay, that's good. But if you look at it grossly, can you see any cyst? The answer is no, you cannot see any cyst. Histology, you can see cyst, but in a gross pathology, you will not be able to see cyst, or you are going to see minor ones, like not a lot. And the size of the kidney will be super small. When you see that constellation of symptoms, this is basically the definition of this guy. Autosomal dominant tubular interstitial kidney disease, also called medullary cystic kidney disease. It causes tubular interstitial fibrosis and a progressive kidney insufficiency with an inability to concentrate the urine. Notice what they write here. Medullary cysts usually are not visualized. Well, were you able to visualize them here? Can you see any cyst in this specimen here? You cannot. So yeah, you cannot see them. And the smaller kidney on ultrasound, it has really poor prognosis because your whole kidney is not working. It's autosomal dominant. So will it have early presentation or late presentation? Late presentation. Look at this patient. His kidney is huge. And let me tell you that he's an adult, for example. So is it autosomal dominant polycystic kidney disease, or is it this pathology, the acute dominant tubular interstitial kidney disease? Is it the first one or the second one? Both of them are dominant. The first one, exactly. In the second one, the kidney will be super small. That's the idea. Okay, good. The last pathology is simple versus complex renal cyst. This is an important topic for the USMLE Step 2 CK exam, but also you need to know it for Step 1. But for the Step 1, you have to know less about it. So simple cysts are filled with ultrafiltrate, which is supposed to be anechoic. Anechoic, which means black. So you take a look, you can see a cyst, but the fluid inside of it is not stained in any way. Okay? This is good. If it's not stained in any way, this is good. Why? Because it's just a bag of water. Yes, that's it. So very common and accounts for majority of renal masses, found incidentally and typically asymptomatic. When you see such thing why we study it if it's really common and it's completely benign? Because it's really common and completely benign. The patient will see that he has such thing and he will be really scared, you know? So when you, just a simple, if it's one, that's the thing. It must be one simple kidney cyst. It must be one, it must be small in size, and it must have clear fluid inside of it. And plus there is one more thing you must know about, that it should not be enhanced. So if you do a CT scan, it's not enhanced. See, totally black. The kidney is enhanced by the contrast. The cyst is not, which means there is no blood supply to the cyst, which means it's not cancer. Because if it was cancer, there will be blood supply. Also, one more thing. Look at its wall. It's pretty smooth. One more thing. It does not have septation. I hope somebody is writing this. So, simple. It has good circumscribed. Also has what? No. It will be pitch black, and also it will have one more thing. What else? What did I say? A few of them, not so many, and it will not have no septation, and it will have what else? Yeah, that's pretty much it. Okay, so the pathological one, the malignant one, is basically the opposite, you know. So the patient will have multiple of them. Okay, if you look at their picture, they will have septation inside of the kidney cyst. Oh, see this one? Many septation. Yes, many septation. And when you see this septation, it means that it's malignant. It's malignant. Septation means malignant. So we go back here, we see that they write, simple cysts are filled with ultrafiltrate, which is anechoic on ultrasound, very common and accounts for the majority of all renal masses, found incidentally and typically asymptomatic. Okay, while the complex one, including those who are septated, which you just saw, and enhanced, which means that they stain with the contrast from the CT, and let's do that actually. So yes, okay, this one has septation, but there is this enhancement in which they look basically, they look white. You look at them and they look white, really. Oh, okay, good. So you can see here the septation, and the septation is even white. Okay, so when you see that, that means this is pathological. This is can be even cancer. Okay, so they write here complex cyst, including those who are septated, enhanced, or have solid component on imaging. A benign cyst should be just a bag of water. If it has solid component inside of it, this is pathological. It requires follow-up or removal due to the possibility to become renal cell carcinoma. Speaking of the devil. Okay, no, I'm not speaking of the devil. Okay, guys, let's just take 5 minutes break, freshen up, come back, speak about this couple of pathology, and call it off for the day. Okay, so see you guys in 5 minutes.